Let's just dive right in. Today, we're tackling a topic that honestly almost nobody actually wants to talk about. We're talking about death and dying. But hey, take a deep breath. There's absolutely no surprise practical exam today, I promise. But here's the thing. As future radiographers, you're going to be stepping into clinical environments where this is a daily reality. And understanding the psychology behind it, well, it's absolutely crucial if we're going to provide truly professional, compassionate care.
But, before things get too heavy, I do have to issue a quick warning. If you decide to sleep through these lectures, your grades might just enter palliative care. Seriously though, let's stay sharp and awake for this one. The insights we're unpacking today are literally going to impact the lives of your future patients.
So here's our game plan for this explainer. We'll start with talking about the unavoidable, move into physical and clinical death, discuss comfort in the final stages, break down the Kübler-Ross stages of grief, and finish up with the incredible power of empathy. Let's get to it. Section 1. Talking about the unavoidable. Understanding the psychology of the inevitable.
Okay, so death is this completely natural, inevitable part of life, right? But the crazy thing is, everyone processes it so differently. So think about this. What factors actually influence how people react to death? Is it A, culture, B, religion, C, personality, or D, all of the above? Just take a quick second. What shapes your own view on this?
All right. If you guessed D, all of the above, you nailed it. You are absolutely right. And hey, if you only chose A, well, you might need to go report to counseling immediately. I'm totally kidding. But it really is this massive, complex mix of all these factors. Culture, your religious beliefs, and just your own individual personality traits. They all kind of weave together to dictate how a patient or even a grieving family member is going to react when they're in your clinic. Moving on to Section 2. Physical and clinical death. Recognizing the biological changes.
So, pivoting from the psychological stuff over to the biological, let's look at the actual physical reality. As death approaches, the body goes through several very specific physical changes. We're talking reduced eating and drinking, profound weakness, shallow breathing, pale skin, and eventually a loss of bowel and bladder control. Now, I do have to point out, if your grandmother suddenly refuses her ugali and tea, do not instantly panic and assume the end is near. Maybe she just didn't like your cooking that day. But in a clinical setting, these changes are exactly what we observe in the final stages of a terminal decline.
The really crucial part here is knowing exactly when that physical decline crosses over into clinical death. And clinical death actually has 3 strict criteria. It happens when breathing stops, blood circulation stops, and brain activity stops. As healthcare professionals, you absolutely have to understand these biological markers, not just for managing the patient, but honestly for your own emotional preparation too.
Let's do another quick knowledge check to see if you're still with me. Based on that clinical definition we literally just talked about, which of the following officially stops during clinical death? Is it A, digestion, B, brain activity, C, hair growth, or D, sweating? The correct answer is B, brain activity. And I've got to say, if you picked hair growth, you have definitely been watching way too many Nigerian movies. Look, while cellular processes like digestion and sweating might take a tiny bit longer to completely shut down, it's the stopping of brain activity that is the definitive, undeniable marker of clinical death.
Let's jump to Section 3. Comfort in final stages. End of life, hospice, and palliative care.
Here's a hard truth. Sometimes, even with all our incredible medical interventions, we just can't cure a disease. But our job? It is definitely not over. The main goals of end-of-life care shift entirely to reducing pain, maintaining dignity, and improving comfort. Think about it. As a radiographer, you might be taking an image of someone who is terminally ill. The way you speak to them, how gently you move them, that literally plays directly into maintaining their dignity during an unbelievably vulnerable time.
You also really need to know the difference between the types of care these patients receive. People mix these up a lot. Hospice care specifically provides comfort during the very final stages of life, usually after all curative treatment is completely stopped. Palliative care, though, that's all about relieving pain and symptoms of a serious illness. And here's the key, it can totally be given at the same time as curative treatments.
So, if you were the one caring for a terminally ill patient, what kind of emotional support would you actually provide? Well, the most crucial things you can do involve active listening, offering real encouragement, without making up false promises, of course, showing deep respect, and facilitating spiritual support if that's something the patient wants. Honestly, often just pulling up a chair, sitting down, and truly listening is the absolute most powerful medical intervention you could ever offer.
All right, Section 4. The Kübler-Ross stages of grief. Navigating DABDA
and emotional responses.
Before we dive into the actual framework, we should just acknowledge the most common emotions people face here. We're talking fear, sadness, anger, anxiety, and acceptance. And let's be real, as students, you probably experience all 5 of these at the exact same time when your CAT results get posted. But out in the clinic, these emotions are incredibly heavy and profound.
When patients or their families get hit with a terminal diagnosis, they usually go through a psychological process mapped out by the famous psychiatrist Elizabeth Kübler-Ross. You've probably heard of the acronym, DABDA. Let's walk down this staircase together. First up is denial. This is where someone just refuses to accept reality. They might say, nope, this lab result must belong to another patient. Next is anger, the whole why me phase. And keep in mind, sometimes patients get angry at literally everyone, even the innocent radiographer who just walked in to position a chest x-ray. Then we hit bargaining, which is basically negotiating for more time. Fourth is depression, just a profound, deep sadness about what's coming. And finally, acceptance. This is where the person might actually find some peace and become emotionally prepared.
Let's see how well you can apply this out in the real world. Imagine you're doing rounds on the ward, and a patient looks at you and says, "Please, doctor, give me one more chance and I'll change my life. I'll never miss church again." Which stage are we looking at here? Is it A, anger, B, bargaining, C, acceptance, or D, denial?
If you said B, bargaining, you are spot on. That is the absolute classic negotiation for more time. And hey, if any of you picked acceptance, well, that patient is clearly still working on a very intense contract negotiation with the universe. They haven't accepted anything yet.
And finally, Section 5, the power of empathy, supporting older adults and embracing kindness.
You know, aging just brings its own entirely unique psychological landscape. Older adults facing the end of life, they're often looking backward just as much as they're looking forward. They might spend a lot of time reflecting on their life achievements. They also frequently have this deep, profound fear of dependence, because really, nobody wants to lose their independence. They might feel intensely lonely. Or, on the other side of the coin, they might reach this amazing state of peace and wisdom. But unfortunately, some do struggle with regret or despair.
Of course, we all know that the reflection on life achievement stage is the exact moment when our Kenyan grandparents love to pull out the classic, "When I was your age, I walked 15 kilometers to school barefoot," right? It's a running joke for sure, but it's actually a deeply meaningful way for them to validate their life's journey and all that resilience they built.
Whether it's your own grandparent or a patient you literally just met 5 minutes ago, the importance of support systems just cannot be overstated. A solid support system helps people cope emotionally, it drastically reduces that terrifying fear of the unknown, it maintains their dignity, and honestly, it just makes them feel cared for. As radiographers, never ever underestimate the power of your own kindness. A simple smile or just speaking respectfully can comfort a patient way more than you probably realize.
So, as we wrap up this explainer, I do have a final piece of advice for you. Study hard, please make sure you sleep enough, and try to reduce your stress for the final exam. But thinking beyond the exams, I want to leave you with this question to chew on. When you are the very last healthcare professional a terminal patient interacts with on any given day, how is your brief moment of empathy going to impact the rest of their journey? Keep that in mind as you step out into the clinic. Stay curious, take care of yourselves, and take care of your future patients.